Hello, I'm Manoj Karmakar. In this next video, Professor Peng from the University of Toronto in Toronto, Canada, is going to be discussing with us the innervation of the hip joint and the role of the Peng block for fracture hip and for total hip replacement surgery. If you're enjoying our videos, do remember to like and share these videos. Also, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Thank you very much, Manoj, for your invitation. I'm going to talk about not just the pericapsular nerve grip block, but I also would like to discuss with you the target Peng generator that you can consider in your strategy for the hip analgesia. This is my disclosure slide, and quite a lot of those slides are coming from these three books, especially the new edition of this book, which probably coming by spring next year. The first area I would like to discuss with you is about the hip analgesia. When we talk about hip surgery, we are talking about a heterogeneous group of surgeries. Just even for the hip fractures, it depends on the size of fractures. You can have a different type of surgeries. And also we have a total hip arthroplasty for elective osteoarthritis management, and we have a hip arthroscopy. In general, you can target your Peng generator according to this anatomical position, like the joint capsule, skin, and soft tissue. Let's talk about the joint capsules. Now, different strategy can help to deal with the pain coming from the joint, and is particularly relevant for the preoperative treatment for the pain coming from the hip fracture or hip arthroscopy. So what are the possible strategies? You can have a pericapsular nerve grip block like a Peng block. You can have a surgeon to do the pericapsular infiltration, and you can even have intra-articular injections by the surgeon as well. The last two was actually done by the surgeon, and the first one was done by anesthesiologist. So I initially thought that the arthroscopy would be a pure model for perioperative control of the analgesia. Until then, when I went into the operating room and see how the surgeon do the hip arthroscopy, in order to perform this well, they use a traction and position device. You can see this is almost similar to those torture device. You can just do something for someone you hate. The amount of traction and also the big choker they put in certainly cause not just the pain from the joint capsule, maybe from the soft tissue around the hip joint as well. Skin is a nice summary of all the skin innervation around the skin incisions. So in general, this is actually the lateral femoral cutaneous nerve. We think that the incision will be enough, which is not true. Now, probably for the dynamic hip screw, the incision will be right over the lateral femoral cutaneous, which is actually depicted in this picture. But when you talk about intramedullary nerve, they involve this color here, which is the iliohypogastric, and also the other different approach, lateral, posterolateral, and even anterior from the front, you always involve iliohypogastric. Now, for the intramedullary nerve, you need a little bit of femoral. For the posterolateral approach, you need a bit black color here, which is superior cranial nerve. So we need a little bit more than just a lateral femoral cutaneous nerve. The question I have is, do we really need a nerve block for the cutaneous related pain? Can we just manage with the multimodal analgesia without doing blocks? The fact is a soft tissue. Now, it becomes a little bit tricky. It really depends on the type of surgery. In general, when you say you put a dynamic hip screw, you make an incision here all the way down, what you did is you cut the tensor fascia lata, which is not coming from anything in the anterior from the lumbar plexus. It's coming from the superior gluteal nerve. Yes, you can go inside and cut some of the muscle for vastus lateralis, which is belong to the femoral nerve. Now, when you actually have the total hip arthroplasty, you have a posterolateral approach. You split the gluteus maximus, which is also from the posterior nerve from the inferior gluteal and superior gluteal nerve, including those from the different small rotator muscle, gluteus medius as well. They are all from superior and inferior gluteal nerve and sacral plexus. None of them are from anywhere in the lumbar plexus. Why I keep on saying this? Because if you actually block the femoral nerve, if you even have the lumbar plexus block, suprainguinal or whatever, you won't even touch any of the structure that involved in the soft tissue. What about anterior approach? Anterior approach for the hip, in general in North America, practiced in 1/3 of the orthopedic practice. They don't cut the muscle, they split between the sartorius and tensor fasciae lata. And here, and from there, they expose the anterior capsule and incise the anterior capsule. For this type of procedure, I think will be a perfect candidate for the anterior capsular infiltration. All right, so we talk about the 3 different possible Peng generators. What about Peng block? Well, Peng block was developed a few years ago because we noticed that there are 3 groups of articular branches that consistently innervate the anterior capsule. And from there, we find that the location of these 3 groups are fairly constant and quite easy to catch. So we think that there is some strategy that we can use for the radiofrequency ablation or chemical ablation, for, which is a denervation for the chronic hip pain. For anesthesiologists, we can put a lot of local anesthetic around the anterior capsule, and then we can use it for the preoperative pain control for the hip fractures. That is the reason why we developed this one. Is there any scientific basis? Well, 2018, we have a very meticulous dissection. We find that quite interesting, that the anterior capsule are supplied by 3 groups of nerve: femoral nerve, obturator nerve, and accessory obturator nerve. They are very constant in the supply and also in the location. For the femoral nerve, the articular branches, most of them, more than 90% of them, they descend around L4 level, and then from there, they leave the femoral nerve and dive deep to the iliacus and then psoas muscle. And then from deep to the muscle, in between the anterior inferior iliac spine and iliopubic eminence, they actually go directly to capsules. It applied for more than 93% of those innervation. And there is some variants in which we call the low branch, that the articular branches that stay with the femoral nerve until in the infrainguinal region they dive directly into or besides the psoas muscle. The second type of nerve is here. You can see the accessory obturator nerve. This is a cutout. This is where this picture coming from. So you can see this is the iliopubic eminence. The accessory obturator nerve can be seen very consistently crossed around the iliopubic eminence. And here you can see the skeleton, and my arrow point to this obturator foramen. And this is actually the zooming of this picture. The obturator foramen is here and give rise to the anterior and posterior division. Now, the femoral nerve and the obturator, they are separate with some fascial plane, but not the articular branches. The articular branches cross below this is called the inframedial acetabulum. Cross below this and cross to the joint capsule and supply the inferior aspect of the joint capsule. So to summarize, the femoral nerve is very abundant, supplying all the 4 quadrants of the femoral head and neck and hip joint, and the accessory obturator supply the medial half, and the obturator supply the inferior half. Now, interesting, there is a systemic review and so-called meta-analysis of the hip capsule innervation, and I don't see any contribution or any additional information from what we are talking about. But one thing that's quite interesting, they use a different descriptor to quantitate and see whether they are good study. And sufficient to say, actually, is we are the only study that strike every single nice point in all the studies, in all the descriptor. Well, what about posterior capsule? I think these two, one is a systemic review, and the other is a recent study from Texas. They shed a light on what are the contribution. These are the 3 nerve to quadrantofemoris, superior gluteal nerve, and sciatic nerve. Now, just in case you don't understand, I think the most important message you need to know is the nerve to QF is the most prevalent and also consistent supply to the posterior capsule, and is basically along the course, you can easily catch that in the superior posterior capsule. And the question is, do we really need to look after this? Well, in terms of a histological staining study back in 2012, this study suggests that the fiber that carry the nociceptive fiber, the Peng fiber, they are more in the anterior capsule, which basically the Peng block is supposed to be, or superlateral, which is weight-bearing area. The posterior area, most of the fiber actually, vast majority of them, they are actually mechanical receptors. So they are not really contributing to the acute pain situation. But we know that the pain pathway are dynamic. So-called mechanical receptor, or some receptor that is not even contributing anything, we call silent receptor. With a certain plastic changes, it can become a nociceptive fibers. And that's what we find. And this is actually a study just published. And based on the 150 patients in Hong Kong who have inoperative hip fracture, so they are left to die, in order to provide a better quality of life. So because they cannot have surgery. So for the 150 patients, they have anterior neurolysis. And then for around 70 to 75% of them, they respond, but the rest of the patient, they have a partial response. So this study basically showed by adding a posterior capsule neurolysis, we can give a significant analgesia. So it confirms what we just said. I think the posterior capsule in general is not really a major contributor, especially in the acute pain setting. Now, the next question to ask is, what about the needle-target relationship? So we go and see whether we can find the target, and turn out that it's not that difficult. If you can align the ultrasound probe between the anterior inferior iliac spine and the inferior iliopubic eminence, you can see these two structure, and you can see the psoas. You can insert the needle deep to the psoas fascia, and you can actually have a spread of local anesthetic along this area. And what if you really inject? Well, we find that when we inject 10 cc, it really spread between the AIIS and iliopubic eminence. It doesn't spread much around the inferior capsule, but you inject 20 cc, and it's quite interesting. We reflect the iliopsoas, we track this up. You'll find that is a capsule. When you inject 20 cc, it really go to the inferior and middle portion of the capsule. And this is important because this is the one inferior capsule, is where the articular branches of the obturator reach as well. We are not the only one, so these are the three articular branches that we need to pay attention: femoral, accessory obturator, and obturator. So we are not the only one who described this. There is an interesting study. They inject dye. And one thing quite interesting, you look at this, when you inject 20 cc, you really actually cover the inferior and middle portion of the capsule. And that, I think, is, we can really say the pericapsular nerve root block is really pericapsular. It covers the articular branches from femoral, accessory obturator, and obturator. But one interesting thing you can see from here, it also spread along the trochanteric area. So we know that in patients with trochanteric fracture, they also respond fairly well. But we also know that the articular branches should only cover the intracapsular fracture. Well, what this study show is, what this a simple dye study show is, the dye can actually spread to the trochanteric area in the extracapsular space and perform almost like a local anesthetic infiltration around the trochanteric area and block the pain fiber over there. So it's very similar to the local anesthesia, local infiltration analgesia, and that's the reason why it worked for the trochanteric fracture. What about the clinical evidence? The evidence is mounting since it's just a baby procedures that started in the late 2018. But the randomized controlled trial is mounting, and I am free to say that just in the last 6 months, there are 4 randomized trials published. They are from 4 different continents: Australia, Chile, Italy, and India. So I'm going to focus on just in 2 particular surgical type. One is a hip fracture. The pericapsular nerve grip block was initially developed for controlling the pain before the surgery because it's very good to deal with the pain around the fracture site. And this was the initial case series. We find that is amazing because if we say the blue is the one before the pain, before the block, and after the block you don't see anything because after the block the pain at rest is zero, except this one who have a metastatic disease in different part of the body, and no matter what, the patient still have some pain. But the pain with movement is the thing that is striking. You see before and after the block, there was a significant drop in the effect size of the pain score with effect size around 7. This is amazing. There's a huge drop. Now, I fully aware that we cannot compare with the fascia block, which basically infrainguinal. I fully aware we cannot compare head to head, but I just look at those Cochrane database and also all the randomized controlled trial using the fascia block and basically the infrainguinal. How much they change in the pain with a movement? In general, the pain difference with the block with movement is around 3.6 across the board. So you can see, this give you a kind of an idea how great is the pain block in terms of dropping the pain with the movement. Now, this is the one I described is the initial study, but it also reproduced in many subsequent case series. And in this scoping review, and in particular these two studies, they are from India. They both actually trying to look at one thing. They do the block and turn the patient and just see whether a patient have pain, look at the pain score. But also one of the category of this is patient have no pain and turn on themselves. In general, when you do this, you have a much higher chance that you can do it on yourself. And remember, the typical trick is we usually give them some drugs to like propofol, just turn them, and they are just amazing. Now, but that is only for the control of the hip fracture before the surgery. What about post-surgical pain? This is an Australian study. It's quite interesting. They compare the pain block with a femoral nerve block. Okay, the femoral nerve block, and I would say it's a pragmatic trial. So why is it a pragmatic trial? Because the authors just let the anesthesiologist choose whatever the anesthetic technique. The only difference is femoral nerve block and pain block. So they can have fractures like intracapsular, extracapsular. They can have different types of surgeries. They can have general spinal. They even can have intrathecal morphine or not. The key is none of them are significantly different from the other. And the result is the first 4 hours, they have a significant difference in terms of the pain. They did not find any difference after this. So the first 4 hours, the pain score is substantial. You can see here, around 2/3 of them, they are pain-free. And here with the femoral nerve block, only 1/3 of them, they are pain-free. But interestingly, the amount of our quadriceps weakness. So you expect the femoral nerve blocks to suffer have a quadriceps weakness, and thanks God they do. They do. So none of them have intact quadriceps muscle function. But then there is also 2 of the out of 30, they have a complete absence of quadriceps weakness. So you can see there is some motor block, but I'm going to comment on this in a moment. The blocking gives a prolonged advantage because actually by day 1, there's no difference. A lot of criticism for this study is actually you cannot just use pain block for any type of surgery, any type of blocks, any type of fracture. So what they have done is, we know that those subtrochanteric or trochanteric, they usually have a dynamic hip screw or intramedullary nail. They go back to do their post-hoc analysis. What they find is if you actually look at this group of surgery, the pain block and femoral nerve block, they have no difference because pain block cannot actually contribute much. But if you look at those for hip, total hip and hemiarthroplasty, the pain block still have a much higher advantage over the femoral nerve block, which makes sense. What about the other hip surgery, the total hip arthroplasty? So there are 2 randomized trial. but I just want to focus on this one. So this is the trial that is a randomized controlled trial. The Italian group have a very interesting design. All the approach is posterior approach, by the way. They have very aggressive pre-op medication, give intravenous acetaminophen, dexamethasone, and ketorolac before the surgery. All of them have spinal, and they do the Peng block after the spinal. But the control group, they instead of just, since they have a spinal, I think they should just simply just put the needle there as a sham block. The control is have no block, just no block. So it introduces a certain bias. At the end, the surgeon infiltrate, but they infiltrate the skin, the soft tissue, but not the capsule. So post-op, they have IV ketorolac and IV acetaminophen. Wow, this is something that our center cannot afford to have those. And everyone have a PCA sublingual sulfentile. And this is the result. Peng score differences are significant over the first 2 days. And obviously, the difference is much more dramatic in the first 12 hours, start to fade a little bit, but they claim they still can find the differences between 12 to 48 hours. And in terms of analgesia consumption, they use sublingual PCA sulfentile. And again, they can find differences between the two. And it is quite significant between the two doses, whereas 2 tablets to 5 tablets over 48 hours. They also find some improvement in the function. In general, the one in the Peng group, they have a much better range of movement, 60-something degree compared with 38 degree, and also they start to walk 10 hours earlier. So this is actually very significant. So I think actually to summarize, there's no doubt that Peng block is a block designed to block the pain from the hip fracture. So it's a very, very good way to block the pain from hip fracture. But in terms of per-operative analgesia for hip fracture, they still find it superior to the femoral nerve block. In terms of total hip arthroplasty, even with a posterior approach, there's evidence to support the use of this. And there is a low, not no, and no, but low, LOW, low incidence of a motor block, which I'm going to address in a moment. Why have a motor block? Let's just pause for a moment. Why on earth we have a motor block? The target is deep to the muscle, deep to the psoas muscle between AIIS and iliopubic eminence. And the femoral nerve is like transatlantic. You have the whole piece of muscle, not a skinny fascia, whole piece of muscle that blocks you from the nerve. Why on earth you have the quadriceps weakness? And on the medial side, the obturator nerve, you have a extension of the fascia transversalis coming down all the way and prevent you, fascia iliaca, sorry, coming down all the way to prevent you to spread to the main trunk. And this is a quite tough fascia, so you shouldn't block the obturator. But as I say, the articular branches able to go through the fascia and supply the inferior part of the capsule. That is a different issue. So there are 3 possibilities that you can get a motor block. One is intramuscular, and I think most of the time it's intramuscular. So when you actually inject 20 cc in the muscle, for those who practice regional anesthesia, you know the magic or the secret of regional anesthesia. If you put 20 cc somewhere close to the nerve, you will get to the nerve. And this is actually what happened. So this is actually if you inject in the muscle, there's a chance that you can spread to the femoral nerve. The other possibility is you are putting too medial and inject very high volume. Some of the Peng block literature, they put 30 cc. The fascial junction between the patenus and the psoas are not perfect. You can actually break through this one and spread and retrograde and go back all the way to the femoral nerve. And the third actually is that you can go the other way, but this probably have you to block the lateral femoral cutaneous, but not the motor nerve. So why muscle injection can cause the block? So why happen? Well, I'm pretty sure a lot of people who perform Peng block and say, I don't inject in the muscle. I'm pretty sure I inject deep to the muscle. So let's talk about what happened. I think anyone who have done regional anesthesia on the ultrasound, you know that when you puff through the fascia don't just pop when you touch it. You indent, let me say that again, you indent the fascia before you puff through this. Depends on the toughness. Sometimes you just indent a little bit and puff through. And sometimes we see a young patient, you indent probably for 1 to 2 centimeters before you can puff through the fascia. Now, in the Peng block, you have the psoas fascia rest on the bone, and there's no chance you can indent the fascia. You really rely on your brutal force, or I would say the best way to get through the fascia is to put some pressure and rotate the needle, simulating a piercing function, and you can get through. But if you're not careful, you may not puncture through the fascia. Okay, sometimes you don't using my rotation movement. You keep on pushing very hard. And then the next thing is you pop through all the way and jam into this thick, we call iliofemoral ligament. And then the next thing you notice, well, you put a lot of pressure, but you cannot inject because you are jammed inside the iliofemoral ligament. What you have to do is gently pull back slowly, so that you are just at the fascial plane between the iliofemoral ligament and the psoas fascia, and you see the fascial lift. If not, you can just see most of the local anesthetic inject around the muscle. So just want to show you this is a lateral medial, so you put the needle there, you see the local anesthetics lift the psoas fascia. And this actually is a picture that coming from one of the very senior faculty at our site, and he published a lot, well, he talked about a lot about Peng block, and see what happened. So this is a needle, psoas, and you can see here, inject, he showed that it's very nice, and there's a psoas fascia, and eventually you can see some local anesthetic around here. So job done, hooray. Well, I want to replay this video again, but not to look at this. Look at here, look at here. So actually this is only 3 cc. Look at here, you can see the local anesthetic into the muscle at 3 cc. Imagine you inject more, and if someone have a very thin muscle, you can easily go to the femoral nerve. So it depends on the technique and also how thin the psoas muscle. So in conclusion, I present to you some of the target pain generator that you should pay attention for the hip analgesia, how I developed the Peng block, and what is the scientific basis for the Peng block and the clinical evidence, and to discuss with you and share some experience with you about the pros on the motor block. With this in mind, thank you very much for your attention. That is my not my only social media, and wish you all have a Peng day. Thank you.